Well, it's so exciting to be here in Tennessee again. Oh, how I wish I was actually there with you in person at the 24th Fall Symposium. And maybe next year I will be able to see you all in person. Wouldn't that be the best treat? Well, today I'm here to talk to you about collective intervention strategies, or what I like to refer to as CIS, as opposed to all of you being fans of NCIS. And this is actually a schema that I developed after Rutledge. Well, I had developed it after Rutledge invited me to create a textbook. And the textbook is called The Definitive Guide to Addiction Interventions. Fancy title that they gave it, but I with a hyphen, collective intervention strategies. So a little bit about me again, for those of you that haven't met me. I'm a clinician, I'm an educator, an author. That's a picture of me and Teddy, which is one of my dogs, with my latest book, Addiction in the Family. But most of all, I'm a woman, a wife, a mother, a grandmother, an adventurer, and a swimmer. And I've had the good fortune of publishing 3 books. Today, we're really going to be talking a lot about what's in my second book, which is The Definitive Guide to Addiction Intervention, Collective Intervention Strategies. And, you know, I always answer my own phone, and I welcome if you choose to give me a call if you have any questions. I will always make time for you. So how are you today? Oh, isn't that the most important question we can ask anybody? How are you? And stop and listen. You know, how did you come here? Did you come here because you needed CEUs and you're just sort of a visitor, or you're a customer of this event? Or do you just want to complain because you've got to do these CEUs or something? But every time we go somewhere or we meet a client, they come with different roles. And you want to see, how does your client show up, or that first caller show up to you? And, you know, there is no doubt, nobody can disagree that 2020 and 2021 have been tough years. Just think about personally what you've experienced. Just think about what our nation as a whole has experienced. Suddenly we were walking around talking, and then COVID hit in March of 2020, and the world stopped. Think about the natural disasters. I know in Tennessee, you had some just terrible rains. I'm out in California, where actually Northern California was just hit, very hard hit 2 days ago, but we've had fires, racism, we've had Zoom school, not Zoom school, masks, not masks. It has been a tough year. And all of a sudden we have this new COVID variant called the Delta. We just don't know what's going on. And I hope, like all of you, you've had the good fortune of being vaccinated. I already had my booster, and, you know, I hope for everybody that they're able to do that so that we can feel some sense of herd immunity. But, you know, I guess all of you, and I wore my heart today, woohoo, because we're counselors. And most of you, no matter what your role is, whether you're a physician, whether you're a psychiatrist, whether you are a social worker like myself, a marriage family counselor, an alcohol and other drug counselor, a mental health aide, you know, very often we put on our Superman and Superwoman capes, because what we want to do is help other people. And we also want to do no harm, but we want to be able to pave a way so that people can thrive. But how do you really feel? So during COVID, I thought like, it's okay to be grouchy because nobody was talking about feelings and how we're able to share our feelings. So if you're feeling grouchy today or going, oh no, not another day on Zoom, I totally get it. And I just want to affirm you. And I also want you to be able to affirm those people that you work with. If they're in a no good, very bad day, it's okay to be grouchy. It's okay not to be okay, which is a major assumption of mine when you're looking at people through a strength-based perspective. And I just want to take some time for a moment just for you to breathe. A couple years ago, I had the privilege, and it was a privilege, of traveling to Bhutan. And this is probably the world's largest golden Buddha. I mean, it dwarfs everybody. But when I was traveling in that country, I don't care what your spirituality or your religious persuasion is, one of the things that I learned there is how to be mindful. And is your mind full? Like, I'm thinking of about 120 different things I have to have for you. Or are you being mindful? Are you being present? Are you able to turn off that phone? Are you able to be in that moment with somebody else? Because that's really key in terms of developing relationships. So what are my hopes today? I'm going to demonstrate, identify, and describe what I mean by collective intervention strategies. I'm going to describe how shame, trauma, addiction, mental health, physical health affect families. And I'm also going to demonstrate the power of family mapping, because that's something that I believe is it is a great way into story, and a great way that is a non-judgmental way into story. And I use it exclusively when in with collective intervention strategies. And I'm going to share an invitational vocabulary, because really what we're doing is when people's hearts are hurting, we're inviting them to change. So I'm going to try and demonstrate through case study both what we mean by clinical and reverse interventions, whether they're in the home, whether they're in a behavioral healthcare center, or they're in a schoolroom, or even in a courtroom. How do we invite people to change, and what are our opportunities? What kind of teams do we put together, and how can we go about doing this? And in the end, what we're really trying to do with an identified loved one who's experiencing mental health, a substance use, possibly process disorder, chronic pain, we're trying to create possibility, but we're trying to create possibility not only for the identified loved one, and I do call the patient or the client or the identified client an ILO, identified loved one, because there, for the grace of God, goes someone else. But how do our clients arrive? I mean, how do your clients arrive? They arrive with substance use disorder. Today, we have seen, if you know the stats, there's an increase in use and selling of alcohol. Beer is the number one. It increased by 55% last year. We have seen an increase in the use of prescription and non-prescription drugs. We have seen an increase most recently, even for older adults, the use of cocaine. We have seen across the board an increase in substance-induced psychosis from marijuana amongst different people. And we've seen an increase, I have an interest also in people that are aging, in per capita buying of cannabis. With COVID, we have seen an increase in mental health, in depression, anxiety. And then with chronic pain or other physical modalities, we know that people oftentimes have pain body, which I'll talk about, and their bodies become the vessel where they hold their fears. The other thing that we have seen, and that I'm sure that many of you have seen with the advent of Zoom, is digital addictions. People are spending, during COVID, they never left their rooms. Young people have gotten lost on their screens. And we're seeing an uptick, not only in digital addiction, but I recently wrote last week an article on digital addiction plus agoraphobia, the notion that we're afraid to leave our houses, and other process disorders such as sex, gambling, disordered eating, and trauma. I'll talk about what I think both trauma is both subjective and objective. And I don't use big T, little t, because it's really in the eye of the beholder. But our clients arrive having experienced or felt like they're not good enough, not smart enough, or there's been something that they have actually had been subjected to, which causes them flooding of thoughts, et cetera, et cetera. Relationship failures, legal incidents, and also, hospitalization. So take a look and think about how do your clients arrive? And so most of the time when I think about a client today, and I did write a Huffington Post article a couple of years ago, and I talked about more than triple threat. People arrive today with substance use disorders, with mental health, anxiety, depression, bipolar, possibly schizoaffective, narcissism, et cetera, chronic pain, could be fibromyalgia, could be migraines, could be back injuries, could be neck injuries, some type of physical ailment, and then process addictions, which you already know. So when you're looking at a family, especially when you're doing interventions, you have to really do an excellent retrospective biopsychosocial, but you don't do it I don't do it in a traditional fashion. I do it through family mapping, which I will talk to you about. You know that I always use the ASAM definition of addiction, and of course there's a brand new one, 2021, but I like the idea that what ASAM says, that addiction is a primary chronic disease. And when we think about it, those of you that are doctors in the room or anybody, let me ask you, what is the most resistant disease? Heart disease, diabetes, substance use disorder, cancer. What is the most resistant disease? Well, I don't know exactly what you guessed, but most of the time people do not guess diabetes. And diabetes is actually the most resistant disease as evidence-based. But like heart disease and diabetes, substance use disorders are chronic, progressive, and left untreated, fatal. They also are primary brain disease because it changes the neural functioning of motivation, memory, and related circuitry. And what happens is our brain gets attached in another area, and that leads to dysfunction in the way we relate to people, who we hang out with, how we see ourselves. And we're always constantly pursuing relief through mind-altering substances or through other types of process addictions. So I like that definition. And that doesn't absolve, a lot of people say, well, does that absolve you of responsibility? No, just like the diabetic. And actually, Miller and Rolnick, if you know motivational interviewing, I'm much more like Rolnick than Miller. I know because I was trained by both of them. But that, in terms of that was actually developed in hospitals with diabetics and also in prison setting. But the idea is that you can motivate someone to change, which is a strategy. So here we have the current definition, which is a treatable chronic medical disease involving complex interactions amongst brain circuits, et cetera, et cetera. And I love to use this when I'm actually doing psychoeducation with families who call me up, because they may oftentimes see it as a moral failing, as opposed to what it is, a dis-ease. And sometimes I'll go DIS-EASE as well. So what types of behaviors do we consider addictions? And by the way, I do not use the word addict or alcoholic or anything like that. Food and eating, gambling, we've talked about the sex, love, work, shopping, debiting, internet, and enmeshment. I mean, for some reason, and you might look at these somewhat as obsessive compulsive behaviors. When we talk about chronic pain, what are we talking about? because I think it's really important that you take a look when we're doing these family maps and beginning to work with people, that you take a look at their physical well-being. And chronic pain affects 133 million people experience chronic pain. That's a 1 in 5 globally. 153 billion was spent on adolescent chronic pain alone in 2 years ago. And 65% of all people experience chronic pain once in their life. 75% of all heroin users started with a prescription. And we don't have to go over the history of hydrocodone and what happened. It was right around Halloween in October 2002 when President Clinton at that time told emergency room doctors, there was a law that said you had to say when you went to the emergency room on a scale of 1 to 10 how much pain you're in, and pain is completely subjective. So my 5 might be your 10 and everything, but at the same time, Pfizer had developed hydrocodone, and nobody knew quantity or frequency. So what would happen is if I went in, broke an arm, had something happen, and I was given a prescription of hydrocodone, and I came back and I said, next week, hey doc, I'm still in more pain. The quantity and the frequency, the quantity and frequency of taking would be increased from that. But what happens with pain is that people have anger, frustration, sadness. Family dynamics are really, really different when you're doing interventions. If you're coming from a chronic pain mindset, because there is a litany of physicians who have given a diagnosis, and it's hard for families to understand that the dependency on some types of prescription medications or overprescription or starting to take them has to do with a substance use disorder, which it can come to. But when you're in pain, you have just, again, changes in the brain, you have poor sleep, you have strained relationships, decrease, and you catastrophize, and you can be really demanding in a different way. But like, make my bed, take me here, take me there, not capable of going to school, not capable of going to work. And so you're really dependent, and the family feels like, oh, you poor thing, there's something wrong with you. Whereas in a family that experiences straight substance abuse, they may be really angry because the person has done things. Not that the person with chronic pain hasn't, but they've done things that they lied, cheated, and steal. They can still do the same things, but there's a different entryway into working with families. When we talk about trauma, and how many of you have a client that you would say has experienced a trauma? I think we need to take a look at what do we mean by trauma. And I had the privilege of working after 9/11 with the New York Fire Department. And really where the definition of trauma first comes from is Lark Young, who was the director of healthcare equity at SAMHSA. And after 9/11 happened, he just wondered and looked at fourth graders who were near the site of 9/11 and how come some of them were just really traumatized, so to speak, or couldn't move forward. And he found out that if you have in your lifetime 3 or 4 more experiences, which we would consider traumatic, you have you would develop either post-traumatic stress or you would have trauma reactions. But when we think about trauma, we think about it as an overwhelming experience that can't be integrated and elicited in terms of animal defense and dysregulation. And that stress causes physical or emotional harm that you can't seem to remove yourself with. So, whether it's a loss of a friend, emotionally overwhelmed, suddenly losing your house from flooding, which has happened, I know, in Tennessee, being told you're no good. So trauma is objective. What happened? My father died by suicide. My child died of sudden infant death syndrome. I was date raped. I was humiliated. I was lied to. I was bullied. I was told I wasn't good enough. Or it could be an objective event, such as I said, a natural disaster or somehow or other. But that is objective. Something happens to you, or you were in a car accident. That could be that. Okay, so I'm sure you can see that I am now in a different background, and life is limitless, and people have limitless potential. But I have 2 golden doodles. They're about 23 pounds, and they decided they wanted to be visible and vocal. So I've just moved to a different part of my home. So thank you for your kindness. And no, I was not traumatized, but I did perceive the situation as unruly. Well, when we talk about trauma as being subjective, it's really, how do I see something? How do I integrate it in? And Lord Young was great. He had 17,000 patients courtesy of Kaiser. And he found that one of the most destructive forms in terms of subjective is recurrent calling and humiliation. So as you know, there's so when someone's bullied, and we've read too many accounts this year of young people who have taken their own life because they've been humiliated or bullied. So again, trauma, what do your clients though say about trauma? They talk about verbal abuse, they talk about physical abuse, they talk about witnessing a tragedy, not being told something, keeping a secret. And families that experience substance use disorders, secrets reign. Accidents, divorce, death, and we talked a little bit about emotional pain body. Where do you feel stress when something happens? Like for me, it's the side of my neck, but where everybody holds stress somewhere. It could be teeth grinding, night grinding. Where do you hold stress? And you want to know where your clients do too, and when you think about it, like when I experience something, I feel and I think, and what do I do about it? So I want to always close it off, shut it off. And folks, though, are more than their trauma, just like they're more than their substance use disorder. But you have to be able to understand that the person you're going to intervene on has so many different facets to them. And you want to make sure that you're not going to exacerbate through intervention or activate any of their trauma. And so you want to also know about shame. And shame, of course, is that intensely painful feeling of believing we're flawed. And how many of your clients don't believe that they're flawed? I'm not good enough. Brene Brown is probably the most popular writer today that's written on shame. I'm not good enough. I'm not smart enough. And guilt. How many of you have not done something that you're guilty about? Have you ever stolen anything? Have you ever had guilty thoughts? Have you ever lied, made up a confabulation, or gone to the grocery store? Like the grocery store is a great place to have guilt. Like how many times, I guess I'm guilty of taking a grape, or you've made up a confabulation. You've told a story that's not exactly true. Embarrassment, like all of us have felt embarrassed. Sometimes it's pretty funny. How is it I have something like I have an idiolect, I make up words or I mispronounce words, my accent's Pennsylvanian. How do I feel when I'm in public? If I can't sing, I'm not on key? How do I feel, when you're in public and someone goes, ah, ha, ha, and you've been embarrassed somehow and suddenly you're all alone. And you have glass tears. This is a very important picture in the respect that when Elton John came out of recovery and he went to a behavioral health care center in Chicago, that all of a sudden he saw life with different eyes, and he became a collector of photography, so much so that I think he may have he is overbought, but the first photograph he ever bought was glass tears, because he felt he grew up with glass tears. And certainly anybody about John know that he did have a great deal of trauma in his own upbringing. And, you know, when we're dealing with clients and we're getting ready to do an intervention, we have to understand that there's loss and grieving, that there's something of value is gone, whether it's my values or I lost my virginity, or I lost my husband, or I lost my job, I lost my wife. And so there is going to be grief work that's got to be done. But when you meet families, they're grieving because their loved one is no longer their loved one in the way they used to know. And so we have to be very mindful of that. And we also have to be very mindful of what our values are and how we incorporate them and know what our position is. So my philosophy of treatment was really born, and I think you have to say, what is your philosophy of treatment? It was based on Sheldon Kopp, who wrote a book, If You Meet the Buddha on the Road, Kill Him, which really said, like, I'm just a little speck along the way. And the goal is for my clients to far pass me by. It's strength-based, and it's trying to stay in the present and not overanalyze anything. Sheldon Kopp said the therapist can interpret, advise, provide the emotional acceptance, and support the future's personal growth, and above all, can listen. Listen, actively and purposely responding with the instrument of his trade. That is his personal vulnerability of his own tumbling self. This listening is that which facilitates the patient telling his tale and can set him free. So I've always been interested in a story, in listening to people's stories. The second person that I've been greatly influenced by is Dr. Sarah Lawrence Lightfoot, who is at Harvard and wrote a book, The Art and Science of Portraiture, which I got to use, which I use all the time now, but I used a lot when I was working at the scene of 9/11. But she's strength-based, she is collaborative qualitative inquiry. And I think it's really important for you all to know that interventions are based on, on good theory. And the context of the interview becomes really important because it becomes so important that we listen to someone else's story. Obviously, many people are been influenced by Brene Brown, who's another social worker. And she says, you know, when we own the story, we can write a brave new ending. So family mapping, which is really what I do when I'm starting after someone calls me up and says, you know, hello, you listen and their heart is hurting and they engage in terms of wanting to do an intervention. I use a technique called family mapping, which is my strategy, which is a way into story. And what it really maintains is we are the authors of our own lives. We write our own airings. We craft from heartbreak. And showing up is our power. And so it's strength-based, collaborative, realistic, inclusive. I'm looking for goodness. I'm looking to create a positive crisis. And I'm listening to strangers, and I'm asking questions with open-ended questions. So when we talk about invitations to change or interventions, you actually have to invite someone to do that. It's not ambush or anything. So for me, an intervention is an invitation to seek and accept care. Oops. And so if you think about the history of intervention, I'm going to do this really short. The history, if you go to the history books, Dr. Vern Johnson was a physician in Minnesota. He was a doctor, he went bedside, and he wrote the famous book, I'll Quit Tomorrow, where he sort of surprised, he liked the element of surprise, he surprised the patient, and he invited him to change. I was greatly influenced by his best friend, Dr. Frank Picard, who wrote Family Interventions. And I did get to meet Dr. Picard when I was putting together the first graduate substance abuse course in the country. at San Diego State University back in the 80s. And, when Dr. Picard, he was tall and stately. And at that point, he was the director of Springbrook, which was an independently owned behavioral healthcare facility, which is now owned by Hazelton. He thought that his friend Vern was just a little bit too rigid, and he didn't always like the surprises, but he wanted to include the family. And that's really who mentored me first. But their history is known as the surprise intervention. And these, I always want you to if you ever get a hold of them, that was actually the first course outlined from San Diego State, but family intervention is still available, I believe. There are the types of interventions are surprise, which is like the person doesn't know you're coming. You gather together, and really it's considered the Johnson model. The Jays, Jeff and Deborah Jay, do an absolutely beautiful job with this, and you need to take a look at their books called Love First. Ed Storty also does a surprise intervention, and he has a book on motivation, and so does Ken Seeley. He has his own book. I'm only talking about people that have actually written books. I'm not really going to talk about people. There are many people that haven't written books that do interventions, but I'm really only going to talk about people that have written books, but there's other people that do beautiful jobs. For invitational approach, Judith Landau, who has the Arise method, has a wonderful book about how do we invite someone to change. That's a little bit different than what I do. And so does Brad Lamb have a book on the invitational model. And of course, myself, I was invited to write the book, The Definitive Guide to Addiction Intervention. And it was designed to be a textbook. It wasn't designed for, as most of the other books are, to, for families just to pick up, although they can. Systemic, meaning family systems, was Mr. Picard. It was also someone else named Wayne Ryder. Action is really when you're using psychodrama tools, when you're using that as part of the intervention, and they're action oriented. For example, if you want to teach families how strange it is about learning what recovery is and learning to live with addiction, there's a great YouTube video, which is on how to ride a bicycle backwards. What? Check it out, because learning how to ride a bicycle backwards is like families learning how to deal with their loved one in different ways. And so let's talk about collective intervention strategies. Why CIS? Well, it's collective, and then to be successful, there has to be a team of families, friends, colleagues, associates. It has to be an intervention, and that we seek to move, i.e. motivate a person to a place of change. We seek to motivate them to enter into some type of behavioral health care setting. Strategy, because nothing is set in stone, so we have to adapt. The process is needed. We may start working out with a family, then suddenly the person's in the hospital. We need to change where they are. You need to be really flexible. Closest thing I see to that is someone who works in the ER. And I was lucky enough as a social worker to start out in the ER. The philosophical underpinnings, as I've told you, are strength-based, solution-focused. People are teachable. Change is possible. The present is really important. And we can teach people to rise to their best possible selves. Theoretical underpinnings are Salvador Minuchin, Virginia Satir, Bowen Family Systems, Bowlby Attachment, and Family Systems Therapy. These are really old. They're very good evidence-based. There's also motivational interviewing, solution-focused, because motivation is on a scale of 1 to 10. How motivated are you? Solution focus is, so if you're motivated, usually your confidence level is less. What skills? Cognitive behavioral is giving people homework. Acceptance and a commitment theory, values clarification. 12-step or other self-help groups. There's over 368 self-help groups, mindfulness, breathing. In my new book, Addiction in the Family, if you get that, there's always self-help at the end of every chapter and teaching families what to do. For counseling skills, you need listening. If you don't have listening, and in 7 seconds, again, you decided if you like me or you're going to decide. Reflecting, your body language is important, asking open-ended questions and actually listening. And, in terms of counselor social self-disclosure, it's really based on to do no harm. And so one does not need to hear your whole life story. If there's something about you that's important to share, then do share. But remember, your job is to do no harm. And sometimes when you begin to do these things, if you tape yourself, you'll learn how much you listen and how much you talk. And this is what I like to say about myself. I'm the mirror who reflects back their pain, their fears, their voices. I'm the inquirer who asks difficult questions, who searches for evidence and patterns. I am the companion on the journey, bringing my own story to the encounter, making possible an interpretive collaboration. I'm the audience, listens, weeps, and applauds. But make no mistake, I am the Spider Woman spinning their tail. I am the clinician who offers cathexis support and challenge. I am also the stage manager, coordinating the intersection of 3 plays: the storyteller, the narrator, and the reader, inviting your voice into the drama. I just wish I was as eloquent as Dr. Lightfoot was, but I take that all to heart. That's probably the best I've ever heard. So interventions include a village of potential change agents. And, when you're talking to someone, you always ask the first caller, because that's really who is going to be your mainstay, who's important to that person. But not only are you going to ask who's important, you're going to ask them to think of an outlier. Is there someone who was really important to them, whether it was a coach, a teacher, a friend, an employer, who's just an unlikely participant? And the interventionist job, at least in CIS, is to bring people together for common good and to help each one of them become a change agent. And so you have accountability teams. And oftentimes in the beginning, an accountability team, they're sad, they're angry, right? They've tried preaching, nagging, and the loved one or the friend just doesn't do anything. And they have not always set good boundaries. And when I work with families, I tell them that I give everybody no fault insurance. I say that you've done the best that you can do with the resources you have. And now we're going to learn how to do something different. And they're frustrated and they may not have a high IQ about substance use, about chronic pain, about anxiety and depression, but for sure, they're ready. No one calls someone who does interventions unless their hearts are hurting. Nobody. And they have to be in pain. They're at their wits' end. And so what a lot of in the beginning, when you get a first caller, you're joining up, obviously you're inviting them and they want to work with you. You also along the way are doing a lot of psychoeducation. People are learning about how an invitation to change is conducted. They're learning new languaging and ways in which to speak, and they're very, very active in moving someone to change. And when I start working with a family, I give families no fault insurance, as I said, but I also tell them that they're free to tell their loved one that the families have a problem and we're going to find a solution, because it's not working. And that part is really transparent. And, there's a wonderful business book called Crucial Conversations, but an intervention requires a crucial conversation. It's just not talking off the cuff. It's not talking while people are screaming, but it is a crucial conversation. And I want to give you some examples right now. And one of the examples was I had a wonderful client, and I call them the War of the Roses. And this is an actual case study. A family called me up, and they had one of their children was about a 27-year-old female, and the parents were divorced. They actually had no opportunity to be together. In fact, they hated each other with such disdain, because when they were in the midst of getting a divorce, the husband or the former husband drove over to pick up this one daughter, and she wasn't allowed to do it. So he took out the prize rose garden. So you can imagine the anger and disdain that these two had for one another. In doing a family map, which is really learning about her, they had not been together in the same room for over 15 years with this girl who was now approaching 30. And she was really struggling with anxiety, with depression. She was living with an older man. She was using mind-altering substances. And through collective intervention strategies, they were able to sit in the same room together and share individually and be able to say, we're here today because we love and we care about you. And we're putting our differences aside because what we see and what we do, we're worried about. And that's sort of the beauty of a collective intervention strategy. And this young woman did go for behavioral health care. But she remarked that the reason that she went was this was the first time since 15 that her parents, she could generally know they cared. They did have other children. So when we talk about interventions, I also want to talk about clinical and reverse interventions. So a clinical intervention can take place outside. It can be in an office. It can be inside a treatment center. So if you have, I don't know how many of you have behavioral health care centers, and how many of you have clients that all of a sudden they say, I want to go home, or I don't like it here. And sometimes that sort of conversation is just left up to one counselor to talk with the client and to just have him or her do it. But when you're really, I think there's a couple places on the West Coast that are just really great at putting a clinical intervention together inside a treatment center. And usually those are when someone says, I want to leave before they need to leave, or they're acting out and everything. And when you do that, you put together the same family that was part of it, as well as a whole treatment team, so that once again, you're talking from heart, from hurt, from eyewitness accounts, and inviting them to stay. I want you to know that I know there's a lot, and we could spend days on this. There's also something which I coined as a reverse intervention. A reverse intervention, which happened to me before, and primarily in college settings or hospital settings or somewhere. It could be within, if you're a private practitioner, in your own setting. But as a university administrator, for example, I would have a young man who might have wrapped his car around a tree, a young woman who just repeatedly got in trouble and really was suffering. And yet the payers wanted these children to continue in school. One, because they just, sometimes when children go off to college, it's not just the child that gets the sweatshirt. In Tennessee has great schools, but, let's just think about, I don't know all of them, but University of Tennessee or Vanderbilt, it's not just the child that gets accepted, it's also the parent, and they become over-identified with, the school. And so they want them to continue, and they don't want any time taken away because they are having such a challenge. And when we talk about a reverse intervention, I remember Ted, and Ted wrapped his car around a pole on a freeway, and he had no recollection of it. And that was not his first time. And he was really a smart young man, but he was really struggling. And his parents were very involved with the university, and they really wanted to look good. And so they didn't want him to leave, but we did what's called a reverse intervention, which was inviting the parents to allow him the opportunity to go, making sure that he would have no harm done with his classes if he left, but that this was the best thing for him. I also, in a hospital setting, a young woman really needed to go to treatment, and her father just wanted her out. And again, it's calling a reverse intervention when the young identified person or the identified loved one knows they have a problem that they needed. That's when you do a reverse intervention where you're intervening on the family. And I must say that when you start doing invitations to change, 97% of your work up front is with the family or the partner or the loved one, because you have to get them up to speed in order to invite the identified person who's experiencing the problems to change. And so that's why I love doing family mapping, and I love doing all the due diligence of interviewing people individually. So I have, my team has an entire portrait of someone. So we're not going in there sort of blindly, which is a different method. Talked about a clinical intervention, and here's some examples of ones, and with youth escalating and reverse intervention. But as a clinician or interventionist, you have to be able to develop a team. You have to, I think family mapping is a great way to engage everybody. Not everybody wants to do that or has the skill set or wants to take the time. You have to develop a case strategy. You have to be able to give 3 recommendations because you want, and those 3 recommendations have to be based on a retrospective biopsychosocial, but they are cultural considerations and also affordability. And you have to think about treatment, I think, not just in terms of a 30 or 45-day residential treatment center. Most people that come to you, they have been suffering for 1/3 to 1/2, maybe 1/4 at the least of their lives. And so you want to be able to create scaffolding, create a care management that allows that person to thrive. And you want to be mindful of somebody's resources. For me, I operated an at your service concierge capability because I'm at the stage of my life where I'm not interested in having clients that I can't follow that long because I just don't think I'm doing them a good service. You have to make sure that you know what you're doing. And when you start doing an intervention, you start out with paperwork, just like you have, and there's an agreement and initiative. And then you begin, once you have your paperwork signed, and my paperwork is for either 60 or 90 days. Because some people who do interventions, they may be here today, gone tomorrow. That might be 30 days. But the first thing, and it doesn't take that long. We're talking about probably a 2-week time period before you actually do the in-person intervention. But you're going to spend 20, 30, even 40 hours of upfront work, because you're going to gather all this information and do an assessment. You're going to interview everybody individually and get a portrait. You're also going to teach them how to do impact letters, which I'll speak about. And then you're going to set a date, a time, a date for a pre-intervention meeting, and a time the next day for the invitation, and the next day for the actual in-person invitation to change. So family mapping, I've talked a lot about, and I want to talk about, it's a way in to story. And with family maps, families, we do the best we could with the resources we have, but unconsciously we've colluded with the problem. Somehow or other, there's some homostasis which says, it's really great that Louisanne has the problem. It just makes me look better. And this is all done on an unconscious level, but we're used to Johnny getting in messes, Louisanne getting in trouble, and everybody has a role in it. I know that you're probably all familiar with Sharon Wexler Cruz and the way she looked at families, but families get some unconscious benefit. And the thing in recovery is, once that person is no longer the problem, everybody gets to switch and it throws it off. And so you have to have permission. And a successful intervention has the potential to transform just not the identified client, but the entire family. So when you start to look at it, sometimes you may be going to work with one person and you end up intervening on another person. That has happened a lot of times because you've got the whole family system which you are going to intervene on. I can remember one such client that I wanted to share with you about, Harry and Anna. Harry called me up, and he was a successful businessman, but his heart was really hurting. He had experienced the death of a son that they really wouldn't talk about due to overdose. And his wife, Anne, had chronic pain and was definitely abusing prescription drugs. And they had one other daughter, Sarah Ann. They had one other child, Sarah Ann, who had a 2-year-old. And Anne couldn't even get together to go to her birthday party. She couldn't seem to get out of bed and everything. But when I did the family map with them, I learned a lot also about Harry. And Harry had grown up in a family that was successful, but they really bullied him and really shamed him. He had always wanted to be, and I'm changing everything, on the newspaper that his father had owned, but his father sold it out from him. So he really was driftless, and he smoked marijuana, and he was in his 60s and bicycled. And I said, before, there was something that I said, before I can even get Anne to go, I need you to go for an evaluation. And Harry was a great guy, and he agreed to go for a very thorough it was about 2.5 week evaluation. And when he came back, he said to my teammate and I, Dr. Louise, I went with one addiction, and now I came back with 10. After that, we were able to successfully invite Anne to go to treatment. And it was really, really due to the fact that she just could not get up to go to her grandson's birthday. And that just devastated her daughter. And when she went to treatment, she really bonded well with the treatment team. And what really came to pass was that both Harry and Anne had kept the biggest secret of all, and that was when their son Harold had died. They couldn't bring themselves to face that he had died of an overdose, and they'd never grieved. And in the midst of doing their family work, because I had the privilege of being there, for Harry, hawks were always something that was special. And while we were working together, actually a hawk overflew, and they were able to start to cry, to grieve, and to take a look at their lives and begin to rebuild. And, that's an example of, a very successful intervention, in the respects that it was kind, it was compassionate. That doesn't mean that the person you're intervening on always loves you, or thinks the world of you, but that it had the skill to take a look at the whole family and to work with it and work with them. And, I guess the greatest gift I could hear was that they attended a birthday party for a 3-year-old and a 4-year-old now. But that they were learning their own path, and they were really able to grieve the death of their son. And that wasn't the only thing they had, because they grew up in pretty fractured families themselves. But I want you to know, when you're thinking of invitations to change and you're thinking about helping getting that loved one into a treatment center, you really need to just put on a little bit of a wider lens, so to speak. And so when you do this, your conversations take you so many places, and they're going to be open-ended and they're non-linear. So it's not like I have behind me here that I used to have this vision board, but this is really not a vision board. This is based on the first book I wrote, which was Falling Up, which was my memoir. But when you start talking to people, you need to understand, and you always ask people for their photos, ask them to send you photos of their loved ones, of themselves, because you want to be able to see them. But that if you jump and go in people talk in non-linear fashion. They'll talk about what's important, but you're going to ask them really important questions. And so you always say, tell me about your children, tell me about your families. Here's an example. This is not really what a family map looks like when I'm doing them live, but this is the way it looks like in a textbook. So when I'm doing a family map live, I have about 18 different colored pens, and you have to understand that this is done on big butcher block paper, and invite me back and I will do a session and teaching you how to do it. And I let people take the lead and say, tell me about the identified loved one. In this case, the identified loved one is the one that's got the heart around it, and that's Jack. And he's 20 years old. He experienced trauma. He has money issues, but the whole family has had problems. And if you start going around and asking about grandma and grandpa, and you find out they had mental health, they had substance abuse, they moved a lot, some people had multiple affairs, and it becomes a way of being able to really capture resiliency, capture strength. And if you're doing this and you're sharing it while you're doing an intervention, it actually makes Jack know that he's not totally alone. And so it doesn't just follow, for those of you that like the DSM-5, I let people, it doesn't just follow just those categories. We talk about substance use, we talk about learning, we ask if anyone had a learning disability, anxiety, any kind of mental health, medical, billing, rage, anger, all of these different things deserve attention. Did you have multiple moves? What is, religious orientation? What is all these things, perfectionism. So let people, when you're doing this, and again, invite me back and I'll teach you live how to do this. You want to allow people to say what they need to say and do it. So here's a case study that is going right now that was perfect, which is great. So Letty is 38 years old. And as an identified loved one, she's married. She has one child, age 6. And there are 5 children in Letty's family. Her father was married once before, has one son that comes from another marriage, and that woman happens to be deceased. She was a physician and died of cancer at a young age. And Letty is the 4th of 5 children. And this is a tremendously successful family, multiple businesses. Father is also a physician. Mother was very beautiful. She was Miss Arkansas, Miss Alabama. I don't know. It doesn't really matter, but she was very beautiful. And father was a head and neck and plastic surgeon, and appearance was really important. And of all the children, Letty probably was the biggest outlier, meaning she was a little bit different. She was absolutely beautiful. She did have plastic surgery as a young child, but she liked the creative arts, whereas other people, although she had one other sister that was an accomplished musician, and she did not live where their family home was. She's from, the land of milk and honey. And she married someone who was the son of someone famous in the entertainment industry, but they found themselves in a relationship that was tied together by cocaine, a lot of cocaine, a lot of alcohol, a lot of other things. And the young child was really beginning to act out. And there are a lot of resources to surround her, a lot of help, but Letty was very fragile, and everybody was basically afraid to confront her and to invite her to go get the help she needed. And there's some payoff in keeping her sick, but nonetheless, in this case, I often work with team members, and sometimes it doesn't matter because you can be better. In this case, the family switched the entire intervention, which can happen. So you better be flexible. Is set to do, and then the father decided that he knew best, and he was used to running large businesses and corporations, and decided that he could only do it with another medical doctor. So in that respect, the invitation to change was done by two people, and I would be coaching in the background. But in terms of once Letty went to a behavioral healthcare facility where, basic stay would be 90 days for her, and helping get childcare, everything else set up, because she really was not in a position, and neither was her husband, who also needed help himself. So, for their son, both of them need residential treatment for a while, or both of them need coaching. So there are a lot of scaffolding. But in order to do this, you had to be, what I'm saying to you is you need to be really flexible in how you approach, and you need to really go with where your client is. You also have to be able to say when you think something is a bad idea. If someone tells you in the middle, you have to be able to stay in control of the situation, because sometimes people may go rogue in the actual meeting time. So when you're doing this, know that you've done a very detailed family map. You've talked to every player individually. You also, I haven't talked much about impact letters, and you can read about those as well, but they're heart, hurt, and hope. What you want is everybody to write, and you better be prepared to edit what they'd like, sort of what they'd like to stay, and whether they use those impact letters to speak. They all go to the behavioral healthcare center, but it's really what is special about Letty. What behaviors has she done that made your heart hurt, and what your hope is for her. Ed Storty, who's another interventionist who does a surprise method, he'll talk about them as a living eulogy. What would you like someone to say to you, and you're still alive? And so you see them as acts of love and acts of compassion. And those become very important, whether someone listens to them right that second or listens to them there, but they become the basis. And then when you do an invitation, obviously you're doing a family meeting, which with Letty never really took place till afterwards. We had to do it sort of backwards, but that then these also become information for the clinical team at the behavioral healthcare center. And if you're following the person at the behavioral healthcare center, then you can also help them with what would they like to do, what would they like to say, when do they want to share these, and how do they do that there. At the same time, understand that when someone goes into treatment, the first thing that happens is they're going to medically detox 97% of the time. And then they're going to have the team is going to join up with them. And it's really the team at the Behavioral Healthcare Center job to join up with them and to begin to unravel that honeycomb. And when you think about trauma, someone said, well, people might ask you when you're doing an intervention, well, it has to be trauma-based therapy. Yes, it has to be dual diagnosed, has to be trauma. But in my experience, you're not going to do EMDR much past like 45 days in treatment. And that's the sort of thing that people don't understand. It's all based on readiness to change. So, and I wanted to talk about Steve as another character. I think we have a couple minutes left. I don't want to go over my time, but I want to talk about Steve. He's 26 years old, and a lot of people 26 or 24 have been like collapsing. And I don't know whether suddenly you're over 25, you can rent a car from Hertz, or suddenly you realize that you're not 25 and you have to take responsibility. But again, he had substance abuse, mental health, trauma, and he failed to launch. No one's ever asked him to really do something. He's not been able to be the young man he's meant to be, to hold a job, nor has he been held responsible to healing a job. And in terms of this was again a different, it was just a small conversation with two people, but there was a lot, about 40, 50 hours of due diligence that went into before that small conversation. And for him, he felt that there was a lot of things that were happening when he was growing up, that he felt like he was a fraternal twin. He was bullied by his brother. He was treated more or less like an ornament as opposed to being a kid. He grew up in a confusing family. Parents were divorced. It was a very explosive divorce again. And for him, it was just meeting him where he is. He did spend 60 days in a behavioral health care center that focused on trauma. Both of his parents separately, because they were divorced, have done some family work. And, today he's not really convinced that he has to be abstinent the rest of his life. One of his best friends just overdosed and died, which did send him unsettling, but he's working with a coach. He's going to outpatient. His role always with the problem, which is really what has to happen. So, I don't know that I have more time. I was going to tell you about a case with a primary mental health who had agoraphobia, because I just recently wrote about that. And there's a lot of COVID-induced agoraphobia. And this was really tough. And Chase had 3 sisters, a father who was really afraid that he could ever leave it. Chase had a previous history of alcohol dependency, actually spent 5 months in a behavioral healthcare treatment center and was working at a restaurant and suddenly decided he had agoraphobia. And he wouldn't leave home. And although he did take his own medications, so to speak, of prescriptions, but this was really challenging, and you really need to be skilled in mental health in order to do an invitation to change like this, because you've got to have a lot of patience, and the skills are different because actually we had to get someone who hadn't left the house in 2 years to go in a car, not with us, but with his father, to a center. And at the center, they're doing some exposure therapy with him. He's in treatment right now, and he has to have exposure therapy, has to learn how to get into a car to actually go other places. So this is a long haul. And you need to also make sure that when you're doing something like this, that you're working with a behavioral healthcare center that's skilled in mental health, even though he has characteristics, definite characteristics of a substance abuse user, really dry. This is primary mental health. I don't know that I have, time to do more today, but I will leave you with, I always tell, nothing changes until something changes, and 97% of your work in the beginning is going to be with that team that has hired you, those family members. And maybe I'll leave with Maddie, because Maddie was wonderful. I met Maddie. She was chronic pain. She had 10 operations. She was in 6 treatment centers. Her first major accident came at age 14. Her family had a history of substance use, mental health, molestation. She had pain body. There's a question of whether she had been sexually assaulted like some of the gymnasts with the trainer. For the past 9 years, she had been in and out of treatment centers. She was walking on crutches or not walking at all when she came into this behavioral health care center. But Maddie gained trust. The primary clinician is really key to this. And she gained trust with exercises. And she started talking to her therapist. And I did a family map and a family program with this family. And the family was confronted with their own substance abuse issues and their need to detach. And really, it was really what we call community integration approach, where Maddie experienced a difference in the family. And it was interesting. The dad became very involved in Celebrate Recovery, and he did it. Mom never really was able to really detach to the extent that dad did, or she was seeing a therapist, but didn't really to the extent dad did own. But Maddie could be your next client. And if you had just gone with what was the chronic pain and not taken a look and really done all the other work with Maddie, and we're talking about someone that maybe 6 to 7 months, and also a lot of aftercare. But Maddie did go back to college, did join the substance abuse group at her college, and did, ride horses again. So she was accepted to pre-med. And I don't know how much time I have because no one has told me. So Amanda, I can't tell if I'm still going or I'm not going, but I'll keep going till someone says differently. Eric was great to work with, and Eric and his family were great to work with. But Eric, again, is not just your perfect story. Eric was 20 years old when we met him, and he had taken a rifle and shot up, I think something like a 7-11. He was the only son of a high wealth family. He had 2 sisters. He had big time legal issues. He is still in jail. He is serving time. He had substance abuse, anxiety, depression, and ADHD. But he was so cute. He looked like everybody. When I was doing a family program, we did a family map. And again, interventions take place in treatment centers and outside of them. And Eric's family looked like the perfect family. His sisters had bullying and depressing. Mom had a family history of substance abuse. Mom was in recovery. Dad had a family history of substance abuse. But while we were doing the family map, which I could wish, Mom had a brother, and the brother died of a young age. He died young, 30s. And everyone thought he had died because he had a heart attack. And then mom said, I have something to share. She started crying, and while doing the family map in a group, she said, my brother died at age 38. He had HIV. The room fell silent because there was a great deal of compassion in the room. There was a great deal of love. But sometimes when you do a family map, secrets, family secrets become open and they learn about them. And the gift this was that Eric's mom had shared this, because all of a sudden Eric got so excited. He got so invigorated. And he said, wait, I need to talk to someone. And on the side afterwards, not in front of a large group, he was able to share that he was confused about his sexuality. What a gift that was given by everybody being able to share their map, by everybody being invited to change. And it's not this perfect happy ever after. Eric is still serving time because what he did was really hard. But I think he's up for parole, and he's in close contact every week. He talks with the former owners of the behavioral health care facility he's in every week. And so he is in prison, starting up 12-step meetings. So that is successful. That is really good that he's able to do that. So that is a blessing for sure. I have so many other stories to tell you. I guess one other story before.
Sorry, I'm sorry, Lois. We do need to wrap up.
Okay. So in the end, what I want you to do is, I have so many stories and so many things. I just want to invite you to be curious, to imagine, to have a journey. You can all fall out. We can change. We can invite people to change. You can be successful in inviting people to change and using collective intervention strategies. So if you want to contact me, I'd be delighted to hear from you. Again, I pick up my own phone, and I want to thank all of you for your time and your consideration and the valuable, valuable work that you do. So keep doing what you're doing, keep inspiring change, and I cannot wait to hear from you. Thank you.
Hi.
Hi.
Welcome. That was so wonderful. Such a lot of great information.
Oh, thank you.
Yes.
I see we have 2 questions up on the question box. And so the first question is from Toby. Does insurance cover intervention? What if the services are needed but unaffordable? What are their options? So, sadly, insurance doesn't really cover interventions. You're not doing family therapy. So it's unethical to say that insurance will cover that. I think that there's always hope and there's always a solution, and there is a way to coach families on how to do this. There's several books written. My latest book, Addiction in the Family, can help guide people. There are people, you can end up getting help with the Salvation Army. You can end up getting it at Cry Help. There's always a solution. Even no matter who calls me, I pick up my own phone, and I'm always willing to do 15 to 20 minutes. There are low cost or people in training that do invitations to change. You just really have to check out, know who they are, and know what they are doing. So thank you, Toby, for that question. And then Judith Tina Johns asked a question, what strategies do you use to motivate the patient to make needed changes? That's a great question. I guess, in 7 seconds looking at me on video, you decided if you like me or not, or if you could trust me. That's evidence-based. And basically, I can tell you a cornucopia, which I did there, of strategies I use, from motivational interviewing to solution focus, sometimes stop and breathing, being mindful, ACT. I think you have to understand that what you're doing is you're setting a stage for someone to say yes. And how you get to that yes in maybe a sea of no's becomes really important. I think that it is really important to be trained. And by that, I mean beyond just a intervention training. I am a licensed clinician. I did teach on a graduate school level. I'm not saying that everybody needs to be a clinician, but you need to apprentice. You need to learn how to do this. You need to be really careful to do no harm. And you need not to be arrogant. I always work with another team member when I do interventions. I think doing them alone is foolhardy and arrogant. There are safety issues and everything, but I encourage you to take whatever courses are available to you. I encourage you to look at it, but I love the fact that you asked about strategies. Obviously, you're creating motivation, but not alone. You're creating a solution. Because you can have, on a scale of 10 to 10, how important it is for your loved one to change a 10. If you don't have solutions or strategies or real life things in place, that's not going to work. Savannah just wrote, do you have any suggestions on implementing family involvement into a nonprofit where time and resources are minimal? You can always develop a family group. There are people that need hours. I've taught graduate school for years. You could end up having a field placement there if you have either an adjunct or a licensed clinician there, but there's always a way. I don't know if those are the 3 questions I see up there. I don't know if there's any other questions from anybody.
Yeah, I'm not seeing any come in from the in the chat room here. But yeah, those are great questions. You talked about working with another therapist. I don't know if you have suggestions on how to team up with other therapists.
No, I didn't say. I work with another teammate. Usually I team with someone who is in recovery and is a good complement to me. How do you team up with someone? Well, you need to understand their training. How do you work together? I'm pretty egoless when it comes to interventions. I think my teammates are equal. I team with someone who is, I mean, in my lifetime, I've only teamed with 4 different people. One currently is also a trained lawyer and he's in recovery and a trained interventionist, and he's wonderful. Another person is a trained interventionist and he's older. And then I've been having a wonderful time with a young man who's 28. Who is wonderful to join up with young people because I work with family. You have to understand the population that you're dealing with. I've teamed up with other people, but when you go to team up, you have to understand who you're teaming with, how do you work together, how are you respectful to one another, what are your strengths, and how do you complement one another. I could send you over to, I have during COVID developed a YouTube channel. Go to All About Interventions at YouTube and you can see one of my teammates and I talking. And so you can get a real good feel for that.
That's
so
a great
All About
resource.
Interventions YouTube.
Yeah, sounds like a great resource. Good. Well, I don't see any more.
Okay, well, you know what? It's been a privilege meeting all of you.
Yes.
I have a really robust website. I also pick up my own phone, answer it. I write blogs all the time. They're transposed over to Thrive Global. my third book, which just came out during COVID. I do not get residuals from it, but it's called Addiction in the Family, helping families navigate challenges, emotions, and recovery. Some of you might have been with me yesterday, so you might have heard about it, but it's all of $11.99 on Amazon. And it's actually people, or $5.99, I think, for Audible or Kindle. But it's been a great guidebook. How do I know that? It's not because I say it, it's because the consumer has said it. And it's been used in treatment centers across the country. But I thank you, Tennessee. I just hope that we get to see each other in person next time. It would be so, so wonderful. And again, feel free to look me up and find me. And I'm just so thankful for all of you.
Well, thank you, Dr. Stinger. I'm just going to try to hold everyone's attention for a minute more. It's our last session of the symposium. It's been so great to have everybody be involved and have everybody in attendance. There's just one evaluation. You only have to fill it out once. And it's on, I know you've heard Ben say this probably 10 times this weekend or the past 2 days, but it's the evaluation tab at the top of the banner across the website. Click on that and it'll kind of guide you through how to do that. The exhibit hall is remaining open through December 1st. So if you haven't had a chance to go there, do that at your leisure. The sessions will replay through December 19th. And because we had those technological issues with the ethics and technology session, ironically, MHA will be sending an announcement about when that's going to play. It sounds like you're going to have lots of chances to watch that. And also CAPA will have an ethics event on December 7th. And our website is Knoxville Area Psychological Association. I think if you Google that, you'll find it, and you can get information. If you're not a member of CAPA, you can get information, or you can email me, which my name's not easy. Janine Powers, PhD, is JeAnine Powers, which is P as in Peter. You can probably see my name, maybe, phd@gmail.com, and I'll be happy to get you information if you need it. And I guess with that, we will wrap this up. And again, thanks to everybody who participated. And thank you, Dr. Stenger. And everybody have a great weekend and a happy Thanksgiving.
Thank you. Take good care.
Thank you. Bye-bye.